All right, so sinus rhythms. All right, so sinus rhythms can be separated into three different types. You either have sinus rhythm, which is what we should be at right now at baseline. Humans are in sinus rhythm, right? Humans can also get fast heart rates, and usually if it's going through the normal pathways from SC node to AV node to bundle of His all the way down, it can be fast or slow, right? Or normal, right? So sinus rhythm is 60 to 100 beats per minute. If you're faster than 100, it's going to be sinus tachycardia. There's some organizations that want to try to change that, but it's been like this for like 75 years. They want to change sinus tachycardia to 95. It's like, guys, stop. 100 is perfect, right? So yeah, so 100 to 150. When you start getting up higher, you might have something else going on. But usually it's like might be PSVT, for instance. You got to kind of look a little closer and see, I don't see any P waves. They might have PSVT, and we'll talk about PSVT. But right now we're talking about normal, right? Sinus rhythm. And then if we get less than 60, that's sinus bradycardia. The same evil organizations are trying to change to like 55, right? So just make it 60 to 100. It's been like that for forever, okay? So sinus bradycardia, sinus rhythm, and sinus tachycardia. So we're going to talk about each one of these things, each one of these rhythms. And again, we're going to talk about the causes, the symptoms, which are the same, and the treatments, and the complications, which are the same as well for the most part, and the nurse interventions, which ironically are the same almost for every rhythm, unless it's lethal. If it's lethal, that changes your nurse interventions. Otherwise, it's always the same intervention every single time that the nurse needs to do. All right, so normal sinus rhythm. So you've heard of sinus rhythm and you've heard of normal sinus rhythm. What the heck's the difference? Can I just say normal or not? Well, the only time you can say normal is if everything is absolutely perfect. That means the P wave's upright and symmetrical, the T wave is upright and asymmetrical, the QRS is less than 0.12, the PR interval is less than 0.20, the QTC is less than what? 4.5, right? Everything is absolutely pristine. There is absolutely no defects in that rhythm, right? And the rhythm is 60 to 100, right? That is normal sinus rhythm. So that's how you know you have NSR. You can chart NSR, you can say normal sinus rhythm on your EKG strip and turn it in and get a 0 on EKGs because you cannot turn in normal sinus rhythm for your clinical worksheets or your mini care plans. All right, so you could try, but you cannot turn in normal sinus rhythm. That does not show that you've interpreted EKGs. We want you to turn in something spicy. Okay, so something that not too spicy because you can lose points if you misinterpret your EKG. Okay. So anyways, if there's any deviation from that, the P wave has P mitral, has 2 humps on it. That is considered sinus rhythm with 2 humps. If you don't know what the 2 humps are, you can ask. It's P mitral. But either way, maybe the QRS is prolonged. It's sinus rhythm with bundle branch block. Maybe it has a prolonged PR interval. Sinus rhythm with prolonged PR interval, and as we'll learn today, that's an AV block of some sort, right? Or sinus rhythm with a prolonged QTC. Sinus rhythm with PVCs. Sinus rhythm with PACs, sinus rhythm with a U wave, if you want to be fancy, right? So these are all flavor that we add to sinus rhythm. That means it's not normal because it has something else going on. It's like plain noodles, plain spaghetti noodles. So that is normal sinus rhythm. But if you have plain spaghetti noodles with marinara sauce, that might be an ST depression or an STD, right? So sinus rhythm with an STD. All right, or I add some beet to my marinara sauce, that's an STD and a prolonged PR interval. You can have all kinds of things added to it, right? Those are additives to it. If I want to add some Parmesan cheese, that could be some PVCs, right? They could have PVCs and PACs, Parmesan cheese and bacon bits. I don't know what you eat. I won't judge you, all right? So they could have all kinds of things going on. They could also have prolonged QRS amongst all those other things. They could have a bundle branch block. Whether it's left or right, we're not going to have you decide right now. That's after nursing school. So does that make sense? Sinus rhythm with something, right? You can't just say my interpretation of this EKG is bundle branch block. That's just like saying I'm going to eat Parmesan cheese, right? No, you have to say what is the underlying rhythm? What are the noodles? Is it penne? Is it ziti? Is it is it linguine? Is it angel hair pasta? I don't know. I'm also not an expert in pasta. Either way, you have to know what the underlying rhythm is, and then there's other things you can add to it. Okay. So PR interval greater than 0.20, it's probably an AV block, right? It's like 99% chance. QRS greater than 0.12, you got a bundle branch block. You got weird extra beats in there. It might be a PVC, PAC. We're not going to test you on PJCs, but PVCs, PACs we will. The PVCs might have a pattern to them, and we'll talk about the pattern, whether it be couplets, triplets, quadruplets, or bigeminy, quadrigeminy, trigeminy, oh my. It might be any one of those things, right? The patient can have an STD, not like a STD, but an STI, but it could have ST depression amidst their sinus rhythm. Is if they have an STD, are they normal sinus rhythm? No, they're sinus rhythm with an STD. Okay? Well, you could be normal sinus rhythm and STD too, I guess, right? Either way, we got peaked inverted T waves. You have prolonged QTC, and that should tighten the sphincters because patient could go into a lethal rhythm. So that's concerning. Okay, so that's sinus rhythm and normal sinus rhythm. Normal sinus rhythm is no deficits, nothing spicy. All right. So that's all sinus rhythms. So now our heart rate's less than what to get sinus bradycardia? 60. There's no such thing as normal sinus Brady. It's just sinus Brady that is slow. How slow? Less than 60. Okay. So it has all the features. It could even be normal sinus rhythm, but it's just slow. It's not called normal sinus rhythm anymore, is it? Because it's slow. To be normal sinus rhythm, you have to have no extra stuff, and you have to be 60 to 100. If you're less than 60 and it looks sinus, meaning that there's a P wave followed by a QRS, right? That is considered a sinus rhythm. Okay, so what causes sinus bradycardia? What makes your heart rate slow, right? So we can think of drugs or meds. So we talk about different meds like beta blockers, right? What's an example of a beta blocker? Ends in what? LOL, especially the ones that have what mnemonic? Man-babe. So man-babe they are definitely beta-1 specific. They are definitely going to lower the heart rate, right? We got non-DHP calcium channel blockers, right? That's our diltiazem and verapamil. Those lower the heart rate. The DHP ones cause a rise in heart rate. So those ones do not cause sinus bradycardia. They cause reflexive tachycardia. DIG lowers the heart rate, like we mentioned. Adenosine is going to lower the heart rate to 0 for 8 seconds, and then it's going to reboot. And then amiodarone is going to also lower the heart rate, right? It's a K-channel blocker. So meds will do it. And then what about SA node suppression? How does our SA node get suppressed? Well, meds, but what else? So what if the blood vessel that feeds the SA node gets blocked? So that's called an MI, right? When the blood vessel, the heart, the coronary vessel gets occluded, that's called a myocardial infarction, right? So some MIs present with bradycardia, right? They have chest pain, like really profound chest pain that radiates to the arm or jaw, and they got a bradycardia. It kind of clues in the cardiologist what blood vessel is blocked, okay? So you got hypoxia. Hypoxia, if you have hypoxia because of a clot in the way, or you have hypoxia because there's low oxygen going, the heart doesn't know the difference, right? You got low oxygen to the SA node, you're going to get bradycardia. And it's really, really low oxygen. It's like I thought low oxygen caused tachycardia. It does if everything works right. What if your oxygen is so low that the medulla, that is the control center for the autonomic system, dies? Then you can't send out the signal to your SNS to raise your heart rate, right? Same thing if your SA node dies because it has no oxygen. So usually bradycardias are a sign of something severe. Something really wrong is happening, okay? So you have really like cause of bradycardia or die. You are dying in front of your eyes. So they have drugs, right? I for ischemia, which is myocardial ischemia, right? Or they have electrolytes. So ischemia you could also kind of group in oxygen. Oxygen being low because there's a clot in the way, or oxygen low because their oxygen's low, okay? So lights, so your potassium is super high, that's going to cause bradycardia. Your mag is high, your calcium is high, all those things are going to cause bradycardia, okay? If your vagus nerve is tickled, right, what does your vagus nerve do? It's part of what system? Part of the parasympathetic, not the sympathetic. The sympathetic raises the heart rate, right? This is parasympathetic activity is increased. So if you have increased parasympathetic activity, why would that happen? Why would you tickle your vagus nerve? Maybe you're coughing too much. Maybe you're doing too much suction on a patient that's not quite alert. You're massaging the carotids. The carotids, your vagus nerve goes right next to the carotids. So if you massage the carotid, it's going to cause your heart rate to get lower, right? If you're defecating like Elvis on the toilet, you're going to pass out because you get so bradycardic that you're not going to have enough cardiac output, and you get hypoxic. All right, it happens at least 3 times a month where we have patients that have a vasovagal response. Right, they pass out because their heart rate got too low. Okay. Hypothermia, if you're super cold, everything shuts down, so your heart rate shuts down as well. And also hypothyroid. You'll talk about that more with in MedSurg 3 with thyroid disorders. And there's normal reasons why your heart rate might be low, right? When someone's like heart rate's low in the monitor, and you run in the room, are you an athlete? No, okay, so it might be something else. It might be drugs, ischemia, or electrolytes, right? yes, athletes can have lower heart rates. Like who is it? Not Tiger Woods. Who's the other one that's profound? Like Lance Armstrong won testy. So he's, he has a heart like a resting heart rate like 32. All right, but every single beat is like super strong, right? It's going to support his blood pressure because blood pressure is a component of cardiac output, right? In the bottom left there. So cardiac output equals your heart rate times your stroke volume. So if your stroke volume is beastie, right, every single beat is going to contract and push out a lot of blood. Maybe you don't need such a high heart rate, but not everybody is. Not everybody has one testy, but not everybody is Lance Armstrong, and they can't contract as well as everybody else, right? So they, normal person, 60 to 100, 50 to 100, 45, they can tolerate a good blood pressure. But once you start hitting under 50, that's going to start causing some symptoms. And what are those symptoms? They're all symptoms of poor cardiac output, right? You have no cardiac output to where? Where does blood go? It goes to your brain, right? If you don't get blood flow to your brain, what do you get? You get confused, you get altered, you get seizure activity, you get comatose, you get stuporous, you get obtunded, you get somnolent, you get semi-comatose, you get, what is the underlying thing? Brain don't work, right? So you could say altered. That counts for all those things, right? So a test question could have any one of those 10 to 12 adjectives, but all of those things mean altered, right? So you don't have to memorize all those different things in every single way to describe someone is not functioning correctly, right? Now, if someone can't they have psychiatric issues, that's different, right? We're talking about inadequate blood flow to the brain, all right? So you have poor cardiac output to the brain, that is altered, right? What about to the skin? Poor cardiac output to the skin. They could get pale, right? The cardiac output is pale. They might get cool and clammy because now we have low blood pressure triggering the SNS, and maybe the SNS is trying to fire off, but guess what? They got all these beta blockers on board. The SNS cannot do its thing, right? So they could get fatigued, right? If we're very, very fatigued, we could be a vague symptom that might happen. The heart, you don't get blood flow to your heart because your heart pumps blood out, but it also comes right back around and perfuses itself during diastole. So if you don't get blood flow to your heart, what do you get? Ischemia, but the patient's not going to say, nurse, I think I'm having ischemia. What are they going to say? They get chest pain, right? So they have pain in their chest, right? Muscles will be fatigue. Kidneys, what are the kind of symptoms would you get if you have poor cardiac output to your kidneys? Low urine output, right? So the patient's going to ring the call bell and say, you know what, my urine output is low. Right? That's not going to happen. So that's something you can find over like 2 hours, 4 hours. You say, oh, shoot, the cardiac output, the urine output before was like 75 cc's an hour, and now it's like 20 cc's an hour. That's a sign of the bradycardia really having an effect on their cardiac output. Okay? Or the liver, it's going to just get, it's not really, you can't really, if the liver does get cardiac output, really it'd be like lab results, like the enzymes for the liver, they would be elevated. And the GI system, what do they get symptoms of the GI system? So they got low flow to the gut. They're going to start getting, they might get some abdominal pain. They might get nausea and vomiting because now the gut is not getting its perfusion. It starts freaking out and they start vomiting on you, right? So patients often might present with like MI. When they have a heart attack, they present with just the vomiting. And you really put on the monitor, the heart rate's like super low and they got a huge ST elevation. It's like, well, that's poor flow to the gut causes them to get GI symptoms, right? The thing we're missing there are lungs. What happens if you don't get blood flow to your lungs or your heart does not pump the blood forward? It just backs up. It's going to get short of breath as well, so short of breath. Okay, so there's all the symptoms of poor cardiac output to the brain, altered. Syncope is another word for poor flow to the brain. What is? You're not so much altered or stuporous. Syncope means what? They passed out, right? Because they had low blood flow to the brain. They syncopized. They fell over and they passed out. All right. The heart, they got chest pain. They might say they feel lightheaded as well. All right. They have low flow to the brain. They might say they feel fatigued. Kidneys, we talk about decreased urine output. Got nausea, vomiting for the GI. The baroreceptors will try to raise the SNS and try to raise the heart rate, but there might be something keeping it low, such as like an acidemia, a really, really bad acidosis, or a really bad high potassium level, or really bad high magnesium level, or they're taking digoxin, or they're taking another medication that might suppress the AV node, such as what? You already got a cookie. Who else? Adenosine, what's a neighbor to adenosine? What's that? Diltiazem is a, here, you break off a leg and pass it along. You said adenosine, but it will technically lower rate, but what's the other A in this group over here? Okay, you got to pass it that way. Did you take a bite or did you break it? Okay, good. All right. I select a group partner that maybe shares cookies with you. I don't know.
Yeah, she'll want to share the cookies.
All right, so yeah, so that's the symptom of poor cardiac output. Okay. Also, to go back to the athlete thing, you want to wake up every patient that is sleeping, right? So it's like when you see them on the monitor, they're sleeping or their heart rate's low, you can't run in the room and wake them up every single time. When's the time where you should wake them up? It's less than 42. When you sleep normally, your heart rate can go all the way down to 42. It's going to 41, 40, 39, 38. That is abnormal, right? That's different than people that have one testy. People that are normal, they're going to be, they're going to have a heart rate will go all the way down to 42, but if it's less than that, that is a sign that they need to be woken up and might be something wrong. Okay? Can't be, oh, he's just sleeping. It's like, no, his heart rate's like 31. That's a problem. Okay? So that's the idea behind sinus bradycardia, and all the symptoms are due to poor cardiac output. Okay? So the treatment. So how do you know when someone needs treatment, right? So those are the treatment there, but what are these symptoms, right? So the symptoms of poor cardiac output that they're going to report like right away are things you got to think of as in a jingle. So you're going to say chest pain, shortness of breath, hypotension, confusion. Any one of those means that they have poor cardiac output. Amongst all of nursing school, that means poor cardiac output, right? They have low blood flow to their brain, which is which one of those? Confusion. They got low blood pressure. They got low perfusion in general. That's hypotension, right? The blood pressure is low, and really the hypotension is really what's going to key us in to see that they really need some treatment. When we talk about other rhythms, all right, and that blood pressure gets less than 90, and they have an abnormal rhythm. That tells you that rhythm is causing problems. That's causing issues where we need to step up and intervene. And how do we intervene? This is what we do for every rhythm ever. All right, so you do ABCs. So you do airway. So what's airway mean? It means they're not choking and coughing and causing bradycardia, right? So it's make sure the airway is good. That breathing means that is there oxygen present, right? So is there oxygen present? Or do they need oxygen? Maybe their oxygen is low, right? When your oxygen is low, you could have tachycardias. When your oxygen is super low, you could have bradycardias, right? So either way, ABCs. And C is circulation. Assess the circulation. How do you assess circulation? Don't say cap refill. That could, yes, I'm going to check the cap refill. Watch me. What else? What's a better way to assess if someone has a low, what did I say? What is C? Circulation. Low effective circulation. Blood pressure, right? Check the blood pressure, because if the blood pressure is less than 90, that rhythm is not being tolerated, right? If they're AFib and their heart rate's 120, it's like, oh, they're fine, 120 is not that bad, because you've seen 150, you've seen 180. But if their heart rate's 120 and they have chest pain, shortness of breath, hypotension, confusion, the hypotension is really what's going to gear us towards, well, maybe we need to shock them out of that rhythm, right? So what else? So the next thing, ABCs, and then a 12 lead, because this monitor we have on them is usually just a surveillance, and then we have to investigate further with a 12 lead. So that's usually the next step is going to be ordered as a 12 lead, so you can see what's going on with the bradycardia, what's going on with the tachycardia, right? Do they have some ST depression in another set that you might not see on the surveillance EKGs, right? And also notify the provider. Notify them that something's wrong. You don't just have, oh, they went to sinus bradycardia for like 4 hours and that's all that happened overnight. It's like, well, shoot, why did you tell me they had sinus bradycardia? That's not okay. Okay. So yeah, so if they have chest pain, shortness of breath, hypotension, confusion, we have to fix the bradycardia. How do you fix bradycardia? You give atropine. What does atropine do? It blocks what? It blocks not the SNS, it blocks the PNS. It blocks the acetylcholine that gets released from the vagus nerve. So we're shutting down the vagus nerve. The vagus nerve causes bradycardia, right? So we're shutting it down, and now if we shut down the brake, all we have is accelerator, right? So that means that's going to raise the heart rate. And just a note on dosages, you do not have to know any dosages in nursing school. That is 100% not required of you, Right? If any teacher is requiring you to do that, that is not okay. The NCLEX does not test you on it. No one tests you on it. The only exception to that rule is with ACLS medications. Like in MedSurg 3, we teach you some ACLS medications, and the nice thing is that everything's like one of epi, one of this, one of that, right? There are a few other differences, like amio is like 300 and 600, but other than that, that's MedSurg 3 doses. There's no other reason to know doses. Sometimes we'll tell you low dose or high dose. Like in clinic, like we say, if they're on low dose enoxaparin, that's for this reason, or high dose enoxaparin, it's for this reason. But that's really the only kind of exception to that, where there's no reason to know doses, right? It's just extra memorization, extra material you should not have to know about. All right, so atropine though, dopamine. Dopamine is the precursor for norepi and epi, so it makes sense if I give the precursor, they're gonna make more of the SNS tools, which is our catecholamines like norepi and epi. And we can give an epinephrine infusion. We can hook someone up with an IV and start epinephrine via that IV. Okay. All right. So you could fix the bradycardia with those medications, but does that fix the underlying cause? Does that reverse a beta blocker overdose? Does that reverse someone's hypoxia? Oh, they're super hypoxic. Look, they're turning blue. Give them epinephrine. That doesn't fix the hypoxia, right? So you have to fix the underlying cause. You have to fix the die. What's making them die? Is it drugs? There might be some reversals for the drugs. Notice glucagon, again, we pointed out, was for beta blockers and for calcium blockers, right? And really, you would not have bradycardia if you overdosed on a DHP, right? If you overdosed on a DHP, you would have tachycardia. That's just how it works, right? If someone has ischemia, they have to go to the cath lab where they intervene and open up the coronary vessels. Right? And one of the treatments for bradycardia after you give all the medications is a pacemaker. So a pacemaker is going to pace their heart at a certain rhythm. So if their underlying rhythm is like 30, you can pace them at 60 to achieve a good cardiac output, right? And then we have different kinds of flavors of pacers, and we'll talk more about pacers in MedSurg 2, where you learn about if they work or don't work, and what kind of pacer is what kind of pacer. Right now, you just know is that you slap some pads on the chest, and it can pace them, right? It can fix bradycardias temporarily, right? And then what else? If that does not get fixed temporarily, they just have an old heart, their SA node has died due to old age, they might need a permanent pacemaker, right? So they get implanted with a pacemaker, and they then have to live with all the pacemaker rules, which, again, that's MedSurg 2. We're talking about pacemakers, okay? So that's the treatment for sinus bradycardia, and the lucky thing is that the treatment is always given for every EKG when they have what symptoms? Chest pain, shortness of breath, hypotension, confusion. Any one of those requires treatment. Someone has sinus bradycardia on the monitor, and they say, I'm feeling some chest pain. Are you short of breath? Yeah. Are you confused? I don't know. No. You're gonna ask them. They have chest pain. Then what do? ABCs. What's the C? You're gonna check a blood pressure, and then you call the doctor. Hey, they had chest pain, and blood pressure is 85 over 42. Right? That is a problem. That's they say, okay, let's go ahead and start an epinephrine infusion, or let's give them atropine and see if that fixes it. And then you can then give recommendations to say, hey, I noticed their potassium is 8.2. Well, that's a problem. So they can give you fixes for that. Or you can say their stats like 84% on the monitor, right? So that's an issue. Or they can say they're having chest pain, and they had this chest pain when they had a heart attack before. It's like, well, shoot, it could be ischemia. That could be the reason, right? It's like, so do a 12 lead, and the 12 lead shows ischemia in the other leads, right? Because when you're monitoring at the bedside monitor, the nurse's station or wherever, it's only monitoring like 2 leads at a time. And MedSurg 3, you talk about different leads that affect the heart. You have 12 leads, and different areas look at different parts of the heart. You might not be able to see it. All right, so sinus tachycardia. So switching gears from slow rhythms to fast rhythms, right? So everything here is we're going to talk about fast stuff until we get back down to AV blocks. We'll end slow. Right? That'll be our mood and attention span also at the end of the day. All right, so sinus tachycardias, so it's just sinus, but greater than what? Greater than 100 beats per minute, right? Greater than 150 equals PSVT. It's not always, that's just suggested, I should point out. All right, so just put a question mark. Could be PSVT. Right? Then we kind of investigate further and see if that might be the case. But what's the cause of someone's heart rate to be fast? Well, it's everything we talked about before is what causes your SNS to fire off, right? So you think of all the things that cause it was low blood sugar, low blood pressure, low pH, high CO2, low O2, right? It could just be movement. It could be anxiety, right? It could be agitation, it could be pain. All those things cause the SNS to fire off, right? So all of those are SNS activity. Those are natural things you can look for to see if they are okay, right? If blood pressure is low, how do you assess if someone's blood pressure is low? If cap refills greater than 3 seconds, no. How do you assess if someone's BP is low? You assess the BP, right? BP is less than what is concerning? Less than 90 usually requires treatment. The thing with sinus tachycardia is it's sinus, and usually it doesn't require treatment because you have to fix the underlying cause. That's usually the right answer for every disease process. Like, how do I fix diabetes? Oh, fix the underlying cause. Oh, you mean diet and exercise? Oh, but anyways, it's usually always the right answer. But here, really, for sinus tachycardia, truly does not get treated unless the blood pressure is low. You usually try to fix the underlying cause. Are they hypoxic? Do they have a high CO2 level? And we'll talk about O2, CO2, and pH in our next lecture with diabetes, right? So we're going to talk about, oh, shoot, they have metabolic acidosis. That means their pH is low. They're going to present with tachycardia, right? So fever can do it, infection, SNS stimulation, they're dehydrated. That means you have a low blood pressure, right? And that's going to trigger the SNS to fire off, and you get a tachycardia, okay? We talk about hypoxia, pain, anxiety, agitation. There could be stimulants. They could take a bump of Coke, right? That's a stimulant. That's an SNS stimulant. Methamphetamines are also SNS in a bottle or in a bag or in a rock, right? Those are also SNS stimulants directly on the heart, and that will cause a tachycardia. It's like, why is your heart rate fast? Oh, it's like I don't know. That's, well, let me see your smile. Oh, you're missing teeth. Okay, so it might be meth. It might be meth in teeth. All right. So yeah, so there could be drugs, meth, Coke. It could be Coca-Cola, caffeine. All right. So caffeine can do it. All right. Okay, so yeah, so you have, there could be caffeinated things, it could be cocaine, it could be Coke. These are stimulants that will trigger the SNS to fire off and raise the heart rate, okay? And then exercise, just moving around, moving your mechanoreceptors in your legs and arms and doing squats, that will raise your heart rate in of itself, right? So how do you know someone's symptomatic when they have a tachycardia or sinus tachycardia? They got chest pain, shortness of breath, hypotension, confusion, and you have to fix the underlying problem. If the blood pressure is low, we might fix it with some vasopressors, right? And vasopressors we'll talk about more. Really, we'll touch on it and for next exam, but MedSurg 3 is really we talk about vasopressors, okay? And again, every tachyarrhythmia ever, every time someone's heart rate's fast, they're going to complain of palpitations. Right? They say, I'm feeling my heart's racing, or I got palpitations, right? They might show you their Apple Watch and look, I got tachycardia, right? But they're not gonna hit the call bell and say, I'm feeling sinus tachy right now, right? But so their symptoms for every tachycardia ever is going to be palpitations, and then of course you have to throw them on, do the ABCs, right? What are the ABCs? Airway, breathing, circulation, and then you're going to hit them up with a 12 lead to figure out, well, is it sinus tachycardia or is it atrial, like an atrial rhythm, or even a ventricular rhythm, okay? So if they do have really fast heart rate and you can't fix the underlying cause, we might hit them with a little beta blocker, a beta 1 specific one. But remember, all of our beta blockers, all of our AV node suppression agents, which are our ABCDs, all of them will lower the blood pressure. So if the blood pressure is low and the heart rate's fast, you can't give those medications. Yes, they will fix the problem, but one of them you can give if the blood pressure is low. Which one's that? Who said it? All right, digoxin cookie. All right, so yeah, so that's the idea behind the treatment. When the heart rate is really, really fast, it can cause a low blood pressure. And why does it cause low blood pressure when your heart rate's fast? It's not enough time to fill, right? So you only have X amount of time to fill the chambers with blood, and if the heart rate's like 150, 170, 220, that's not enough time to fill the chamber with blood effectively to perfuse the body, okay? Again, if it's symptomatic tachycardia, we always treat the underlying cause with sinus tachycardia specifically. All right, so now we're going to divide into our groups and then check our work afterwards. All right. All right, so number 1. Who's our first group? All right, so what is number 1? Sinus rhythm. How do you know it's sinus rhythm? You find if it lines up on a line right here. So again, you just find a complex that lines up. And then what's the rhythm? Or what's the rate, sorry? You got 300. What's next? 150, 100, and just above 75. So it's between 60 and 100s. And for it to be sinus rhythm, we have a P followed by a QRS. Is there anything else fancy going on there? Is it sinus rhythm or normal sinus rhythm? It's sinus rhythm, because in normal sinus rhythm in lead 2, technically the QRS is upright. All right, this is just sinus rhythm. Okay. Also, that P wave looks a little bit sus. It looks like there's 2 humps on it almost on some of those, right? So that could be also another reason why that's not just normal sinus rhythm. Okay. So but that QT looks a little bit long too. I don't know. All right, number 2. What do you got for number 2? Sinus bradycardia. All right, so this guy kind of lines up. Is there another one that lines up? All right, so you got 300. What's next? 150, 100, 75, 60. It's less than 60, right? It's about a point less, right? So it's definitely less than 60. So is it sinus bradycardia? Yeah, there's P wave followed by a QRS. There's no like AFib or VTAC or anything else fancy. But sinus brady can have extra flavor just like sinus rhythm can. So anything else going on there? That QRS looks a little bit wide. All right, what is a wide QRS? Greater than what? 0.12. 0.12 is how many boxes? How many small boxes is 0.12? Greater than 3 small boxes. Look at this, just there, right? So it looks like 1, 2 box, maybe 2.5, 3 boxes. So it's getting there. It's concerning. All right, so that'd be like sinus brady with a, you could say prolonged QRS, but it's probably bundle branch block. All right, so what's a cause of, it has a first degree AV block too? Yeah, it does. So you see how the PR, how do you know if it has a first degree AV block? The PR interval is prolonged. So when you come, once we learn AV blocks, you can come back to this and that should make sense, right? So you see the PR interval is greater than, what's a long PR interval? Greater than 0.20. So is that PR interval greater than 0.20? Well, this guy right here, I'm just lining this one up. See, look at that guy. It's just right there. It's just after it. It's like it might even be 0.20. It might be 0.205. I don't know, but it looks prolonged, right? So that's a definition of a first degree AV block. And we'll talk more about AV blocks and how you know it's first degree, not second degree. All right. So we got sinus brady, the first degree AV block, and a bundle branch block as well. And how do you know this patient had what would cause this? What's an example cause of sinus bradycardia? They're on a beta blocker, good. And even with the first degree AV block is really gonna spice that up. And then what's a treatment for it? Not beta blockers. How would you fix this if they were symptomatic? And how would you know they're symptomatic? Chest pain, shortness of breath, hypotension, or confusion, right? So atropine, I heard, right? So atropine would be you guys got saved, look at that. The atropine would be a treatment for bradycardia. All right, number 3, what do you got there?
Sinus bradycardia.
So this guy lines up perfectly. So we got 300, what's next? 150, 100, 75, 60, 50. So it's between 50 and 60, like 57, I don't know. All right, but it's definitely sinus brady. Anything else different there? The QRS looks good. PR interval is less than 0.20. All right, so it looks pretty decent. All right, so you got sinus brady. All right, who has number 4? All right, what is number 4?
Sinus Brady.
It looks slow, so it's line one up. That guy lines up, and guess what? You can go backwards. 300, 150, 100, 75, 60. It's between 50 and 60. All right? Boxes are boxes. You can go forward or backwards, right? But if you use a different complex, as long as it lines up and you can space it out 5 small boxes at a time, you're going to get there. So yes, it's between 50 and 60, we decided, right? Anything else going on with that? That QRS looks different, looks like low amplitude, but also looks bigger than how many boxes is big? And again, you measure it isoelectric to isoelectric, all right? So it looks definitely encroaching more than 3 small boxes, right? Greater than how much is 3 small boxes? Greater than 0.12, right? So we got sinus brady with a bundle branch block. I don't think there's anything else going on. ST segments look good. P waves look good. QT looks a little bit prolonged. I'd have to file that through my QTC calculator, right? Or if you find a calculator that can do square root reliably, you can do QT divided by the square root of the R to R. That'll get you there also. All right, sinus rhythm bundle branch block. All right, number 5. What is this? Looks fast, but how do I know it's fast? Because fast means greater than what? Greater than 100, right? And then so I got 300, 150, definitely close to 150, right? So it's like 142, right? So heart rate is fast. So is it a sinus tachycardia or an AFib or an A flutter or a VTach? How do I know? How do I know it's not VTach? How do I know it's not coming from the ventricles? It's not wide. If it's wide, and if VTach is always wide. I mean, if it's wide, it could be atrial, but I know this came from the atria because it's narrow, 100%, all right? But is it atrial fib, atrial flutter, multifocal atrial tachycardia, something weird like that? Or is it sinus? How do I know it's sinus? I have a P wave followed by a QRS, right? That's how I know it's sinus, right? And sinus rhythm can have extra flavor. It can have bundle branch blocks. It can have AV blocks. It can have prolonged things. Is there anything upsetting with this? Not really. It looks like there's no other deviations. What did I write? Sinus tach. All right, number 6. What do we have for number 6?
Sinus Brady.
Yep, that guy lines up there. 300, 150, 100, 75, 50, 35. So we're all the way down in the 30s. Okay, so that's definitely, is it Sinus Brady or what is it? Anything else spicy on it? The PR interval looks decent. So we're not getting to AV block territory. We got a P wave followed by a QRS. So that's sinus rhythm, right? Doesn't look like a bundle branch block. Looks pretty narrow QRS. T wave looks a little bit elevated. But, no. Sinus Brady. All right, what about number 7? That looks like there's something wrong with it. Who has number 7?
We do. Sinus rhythm with a bundle bridge block.
Yeah. So we got this lines up right there, right? So we got 300, 150, just under 100, right? So we got sinus rhythm with what? We got a prolonged QRS. That guy looks fatty, right? And then also there's something else going on. This guy has an ST depression, right? He has an STD, okay? So we got sinus rhythm with a bundle branch block with an STD, and he has some T wave inversion too. That T wave is not upright. It's actually biphasic. I'd say biphasic T wave inversion, right? It's just not normal sinus rhythm. So when you interpret this, you would not say normal sinus rhythm. That's the key. And when you turn in your EKGs for your mini care plans and clinical worksheets, you're not going to get points taken away if you did not recognize there was a T wave inversion, for instance, or an STD. Well, all we want to make sure is that you recognize something's wrong, right? I mean, if you write a PR interval of 0.24 and then the interpretation you don't write, there's a first degree AV block, that's a problem. If you write a QRS that is 0.16, and then in your interpretation you don't write, they have a bundle branch block, that's a problem, right? But T waves and STDs, that's going to be more MedSurg 3, where we talk about what that means. All right, last one, number 8, or almost last. What do I have for number 8?
Sinus rhythm got elevated ST.
ST I would argue is not elevated. ST segments, again, that's going to be MedSurg 3. There's a certain spot you measure ST segments from. That's called the J point, and that looks pretty even. J point's right here, so that looks pretty isoelectric. But yeah, that end of the QRS segment is very is under the baseline, so it's not normal sinus rhythm. Did we say it was sinus rhythm or sinus Brady? This lines up 300, 150, 100, 75. It's between 60 and 75, right? So that is not normal. That is sinus rhythm, right? Is it normal sinus rhythm? You got P wave followed by QRS, but that S is very, very deep S wave. All right, so just sinus rhythm. All right, number 9. Is that right? Number 9? All right, what do you got for number 9? Who's number 9? Do we forget number 9? Do we need to do it as a class? So number 9, what is that? Sinus rhythm, sinus Brady, sinus tach. So it's regular rhythm, so we're kind of heading towards sinus something. And then we look at this guy lines up perfectly, 300, 150, 100, between 100 and 75. So that means it's a what? Sinus rhythm. Is that normal sinus rhythm? No, that T wave looks janky. So what is wrong? That T wave is inverted. It is upside down. Okay, it should be upright and asymmetrical. All right, so we got sinus rhythm with T wave inversion. QRS is getting there, but it's not greater than three small boxes, right? So sinus rhythm with twee. All right, number 10. What's number 10?
Can we sinus rhythm with ST depression?
Yeah, the ST is very depressed. Right, you can see how that isoelectric line has dipped, right? And it's sinus rhythm because the heart rate's is between what? Between 60 and 100, right? So yeah, so that is sinus rhythm with an STD. Okay, next one.
Sinus tach. Luke said borderline SVT. I don't know.
So P wave followed by QRS is really leaning towards sinus tach.
I don't know.
When we talk about SVTs, usually SVTs, the P waves are hidden or they're like going up onto the T wave. So this is P QRS, P QRS, P QRS, but we definitely have something going on here, and that's an ST elevation.
Yeah, we said maybe J point because we didn't know if it was STE or.
It's STE, it's ST elevation. Mm-hmm. And also you have some PR depression as well. This patient probably has pericarditis. All right, so sinus tach with STE, and you can even argue they also have a PR depression, but we're not going to get into that. That's later. Okay. All right, next one, number 12.
Well, sinus rhythm, is it rhythm? Sinus tach with an R.
So how do you know the difference between sinus rhythm and sinus tach?
I didn't have the number in front of me.
It was about 140.
So the heart rate is fast. How do you know it's fast? All right, you can line it up. You got 300, 150. It's right up next to 150, right? So we got sinus tach with what? Well, it even says patient moves. All right. So yeah, so that's artifact. Okay. All right, top right, number 13.
Sinus Brady with
Yeah, the QRS looks a little bit long. It's getting the long side, right? 3 small boxes. If you look at the first complex there, we've got 1, 2. It's almost hitting 3 boxes already. So we're getting there to a bundle branch block. So is it sinus Brady or sinus rhythm? Sinus Brady with a bundle branch block-ish, maybe. All right? So yeah. So then we weren't asking like what's a cause of sinus Brady? How would you fix it? Infection? No. Infection would cause a tachycardia. If that infection got to the point of severe acidosis and severe hypoxia, you could argue that it caused that, but the first step would be tachycardia. But these are things that cause you to die, right? So drugs might do it. So what's an example drug that might do it? What is it? Calcium blocker? All right, so you already got a cookie, so you can get a gummy. Okay.
Thank you.
All right, so calcium blocker. What kind of calcium blocker? Nope, DHB causes reflexive tachycardia. Non-DHB causes bradycardia, and there's 2 non-DHBs. What are the 2 non-DHBs? Just one person, please, so they can get a gummy. Here, you haven't got gummies yet. Okay, you can pass it along if you don't want a gummy. Okay. You already got a cookie, though. I'm kidding. All right, so what? So treatment, how do we fix this? Ideally, if you answer questions, but you can still get your gummies. Dopamine you can give? Yeah, dopamine is a treatment for sinus bradycardia. It's usually a dopamine infusion, like an IV form. All right, next one, number 14. It looks pretty fast, yeah. So sinus tach, so this guy lines up right there, right? So 300 to 150, it's greater than 100, right? So that is sinus tach. So why is it sinus? Because we have a P wave followed by a QRS. If we didn't have a P wave or the P wave looked funky, it might not be sinus, right? So what else is going on with that? We got some, whoa, what was that? It's some artifact, some movement, right? Or respiratory variation. Okay, and then next one, what's this one, number 15? Sinus tach, how do you know sinus tach is greater than what? This guy lines up, 300, 150, between 100 and 150. So it's sinus tach because we have a P wave followed by a QRS. There's not much else going on with that, right? So QRS is narrow, P wave's okay, ST is okay, T wave's okay. So sinus tach, what's a cause of sinus tach? Stress, Nursing 103, Monday, January 8th, 2024, all right? Yeah, drugs can do it. What kind of drugs? Meth, coke, okay. All right, number 16, what's that? Who has number 16? Anybody? All right, I'm going to take the gummies away. All right, what's number 16? So what's the rate first, right? So the rate is what? This kind of lines up perfectly, 300, 150, 100, between 75 and 100. So it's a sinus rhythm of some sort. So anything else going on with it? Not really. Really have to be technically more than 1 millivolt or one small box. Looks pretty decent. T wave looks fine. It should be asymmetric. Looks like you could argue it might be symmetrical. This is just normal sinus rhythm. It's perfect. Okay. All right. Last page, I think, right? Number 17. Who has 17? Who has 17? You've had an extra 15 minutes to interpret. What is 17? So what's the rate first, right? So what's the rate? So it's between 60 and 100. That means it's sinus rhythm of some sort, right? If you don't have this third page of exercises, you probably have the old PowerPoint. It looks just like sinus rhythm. There's not much else going on, right? There you go, sinus rhythm. I'd argue it's normal sinus rhythm. I can't identify what else is going on. So normal sinus rhythm. All right, so then number 18, what's that? It is funky, but what is the official interpretation? Yes?
So is there like a certain metric for ST elevation, or does it just like...
There is, and you'll learn that, yeah, you'll learn ST elevation, ST depression in MedSurg 3, because that indicates ischemia or infarction, and it's usually greater than 1 millivolt, and it also depends whether you're male or greater than 45 years of age or not. No. So ST depression, not really, because the ST segment is nice and even, right? But that T wave is biphasic. It is up and down, right? So that T wave is not okay. So they got sinus rhythm or sinus tach? Is it sinus tach? What is it? So this is 300, 150, 100, 75, 60, right? It's between 60 and 75, so it's sinus rhythm. So it's sinus rhythm with a biphasic T wave. And also that QRS looks more than 3 boxes, right? Doesn't it look longer? Right, so you got 1, 2, barely. So it's borderline bundle branch block. What do we? Yep, sinus rhythm bundle branch block and biphasic T wave. All right, next one. That is ST depression. Look at our baseline here, and look at the ST depression. So is that sinus tach or sinus rhythm? It looks too fast for Sinus Brady, right? So it's sinus tach with ST depression, right? All right, and number, whatever that is, 20, what is that? That is artifact, right? It's like 60-second interference. It's someone having a LAN party in your patient's room. It is not it's really, I mean, you could interpret it, but you can't really see if there's P waves or not. All right, who's playing Fortnite? All right, 21. Looks like sinus rhythm or is it sinus tach? Is it too fast? What, is it below 100 or above 100? Below 100, so it's not sinus Brady. It's not that slow. So it's sinus rhythm with what? Is it normal sinus rhythm or sinus rhythm with something? I'd say that's peak T waves. Right? Those T waves are nice and peaked. Look at normal T waves. Look at peaked T waves. Right? And peak T waves are a sign of hyper what? Hyperkalemia. All right. What's the next one? That one looks pretty slow. Is it slow? Yeah, that one lines up, and it's definitely slow. Right? So that's sinus what? Bradycardia. What's the cause of sinus bradycardia? It's like one testy. All right. So, or he could be an athlete. All right. Or they could be sleeping, but really that might be less than 42. So that might be something else going on. They could be hyperkalemic also. All right. All right. Next one. We got some. You can't really assess that greatly, right? So you could say some respiratory artifact or artifact in general. All right. And then last one, number 24. So that is pretty fast, right? That is, let's line this guy up right here, lines up 300, it's almost 150, right? So that's a sinus tach. All right, so we'll do the next section, and we'll take a quick break. So we're moving on to